Thank you very much, Hello. Thank you so much for being here. I'm so very proud to be the award winner of the Karolinska for 2012. I thank the president and I thank the Karolinska Institute as well as the foundation. It's been a tremendous honor, and it's enormous. The amount of reactions that I get across the world is just phenomenal. I'm not Hank Schmidt, but to some extent I don't mind, because my talk later on will be about the future, an outlook to the assessment in the future. And in order to do that, it is wise to look back, because it's based on, I think, quite some research. And this change allows me to summarize the past in order to look forward later on. Okay? You may find my PowerPoint at the URL down there. And I'll pause for a minute for you to write it down. I'm very much used to an interactive lecture, but unfortunately, we cannot allow that today. But we have the Billabong sessions afterwards to debate and to interact, and we have a forum session as well. I'm going to talk about research that has been done around the assessment of competence in medical education. Fortunately, that is an area that has been thoroughly investigated. Over the past 40, 50 years, we've seen a lot of developments of innovation in the assessment of competence. And a lot of our research was associated with that. I'm going to summarize that research. I'm going to interpret it, actually, in terms of what I consider to be principles of assessment that may be generically used as a background information when you approach assessment. Who's not familiar with Miller's pyramid? Does anyone? No, that's great. Because basically, what we've been doing is climbing Miller's pyramid as a simple assessment model of competence. And in order to describe those developments, I need to explain a little bit of a theoretical thing. Any sort of assessment can be characterized by the task you give to the candidate, the stimulus format, and the way you capture the response. The way you can capture the responses, for example, in a short menu, as it is here, could be a write-in, could be an essay, could be an oral response. And the stimulus format is really the task. That can be factual, it can be contextual, it can be a performance situation, it could be a real situation, and this is how we basically climb the pyramid. And over the years, we've been climbing this pyramid. We've been moving from factual knowledge test to stimulus formats that required application of knowledge, scenarios, vignettes, and I'll come back to that later on a little bit. And we've been moving on, and one of the big founders, we've been moving on with performance assessment in the simulated setting, which was actually proposed by Professor Ronald Harden in the 70s with the objective structured clinical examination, which were real performance situations in a standardized form where people were being observed, and we had a sort of a round-robin situation, people going through different clinical stations. And basically, this is the level where we are in actual practice. We're talking about the assessment of habitual performance, either in a clinical situation or maybe even in an educational situation. So this is the unstandardized world up there. Basically, this is where we are currently with assessment technology. And I think that, to be bold, I think that most of the standardized assessment technology is well established, kind of established, with lots and lots of research around it. And this is where we are, the non-standardized assessment. We're moving back into the dirty world of non-standardized testing in the real setting. What I'm going to do is I'm going to summarize the research. And I'm going to do that separately for standardized assessment and for non-standardized assessment. And for each of them, I formulated 6 principles. Here's the 6 principles for the first 3 layers for the standardized assessment, and I will go through them individually. The next 6 for the top level of the pyramid, unfortunately, is past my half hour. So I will only roughly sketch 1 or 2 things around it if there's time. So let's move to the first assessment principle. That is what we found time and over again, is that performance on a particular question, situation, essay, station, or whatever you have, is not very predictive for performance in another context, in another station, another problem. So actually, performance is very variable. And it doesn't really matter what you're measuring or what you're measuring it with, you will always find that performance is variable. So if I would take 2 essays to assess the competence of an individual, those 2 essays will very differ from each other in terms of how they rank an individual. That's a headache for assessment, because it means that if you want to make an inference about someone's ability, you cannot do it on a very limited sample of observations. If performance is very variable, you have to have a large sample of observations in order to make an inference which is no longer dependent on the particular sample of observations giving. And that's a headache. Here's a summary of reliability studies. Reliability is the extent to which a measure is reliable, is accurate. If I were to measure your length and I would do it twice, I would expect a high correlation between the first measure and the second one. In the literature, one says that for, let's say, summative decision making, you need at least a reliability of 0.80. And here are a bunch of different assessment instruments, basically ranging across Miller's pyramid: multiple choices, short essays, simulations on paper, oral exams, long cases, OSCEs, mini CEX in actual practice, videos in actual practice, and fake patients, which we send out to doctors' practices, where the doctors didn't know they were being visited by a simulated patient. And these patients were completely trained to score the performance of doctors. But as you see, you need quite a few hours of testing time in order to come up with a reliable score. So generally speaking, many of our tests, exams, are pretty unreliable. Or yet in other words, we make a lot of false positive and false negative decisions because of unreliable exams. Bad news. Sorry. So, you know, what's the consequence? The consequence is really that one measure is no measure. You already knew that from your clinical background. I mean, you wouldn't, I'm on blood pressure medication. That decision wasn't taken on one measure of my blood pressure. Right? So we need a lot of different measures, particularly if the implication of the decision is of a high stake. So therefore, we need to combine information across different samples. From different sources or from repeated measures, we need to combine information as much as possible. Am I making myself clear? Yeah? Right. The second assessment principle, kind of, I gave away in the table. That is that one of the holy grails, naturally, of any form of assessment is objectivity. But objectivity should not be confused with reliability. Now, let me make that a little bit more clear. Here's that table again. Multiple choices are often used because they're very objective. Essays or oral exams are often not used because they're so subjective. However, as you can see from this table, more subjective measures can be reliable and less subjective measures can be more unreliable, all depending on the sampling that is behind it. And let me make that a little bit more clear. Let's take an oral exam, and I am a candidate, and she is my examiner for the first case, and she's my second examiner. Oh, sorry. She tests me in all cases, okay? And the reliability doesn't increase. Why? Because she quickly forms an impression of me which she doesn't change across cases. Now let's assume the situation that she's my first examiner on the first case, second examiner on the second case, and so on and so forth. This is what happens. Then reliability starts to come up. So actually what it says that multiple subjective impressions, evaluations, can make up a reliable overall picture, which is a very important message. Actually, having two examiners, so they are the two examiners of the first case. These are the two examiners of the second case. It proves a little bit, but not that much. If we have 4 times 2, 8 examiners here, we might as well do this and achieve better reliability. So reliability is a matter of sampling, and if you sample appropriately, you can actually sample in more subjective areas, which is pretty important. Remember that for the top of the pyramid, we need to assess performance. That needs to be judged, that needs to be observed. That is inherently subjective, and therefore, I think this is a very important message. Actually, Professor Harden introduced the OSCE, the Objective Structured Clinical Examination, out of dissatisfaction with the traditional subjective clinical examinations, and he named it Objective and Structured. Now, after so many more years of research, we found out it's not in the objectivity, nor in the structuring, but in the sampling where the reliability comes from. And that principle can be applied to the top of the pyramid, to the more subjective nature. Okay. So actually, I think that we should not be afraid of more holistic, professional, expert judgment, provided that we harness it in sufficient sampling. Right, let's move to the next principle. What is being measured is more determined by the stimulus format than by the response format. Stimulus format is the task we give to the candidate. Response format is the way we capture the response. Often I hear people say, I dislike multiple choice items because they tap into measuring facts. And I like essays because they tap into understanding. In itself, this is nonsense. It all depends what you put into the assessment that determines what you're measuring. You can measure very silly factual things with an oral exam, if you wish. And you can actually assess higher cognitive problem-solving skills with multiple-choice formats, all depending what you put into the format. Give you an example. Let me show you. This is a simple factual knowledge question. I can reframe that question in such a way that it's still a multiple-choice question, but now it taps into higher cognitive skills in clinical reasoning. Actually, if you look at the North American certification exams, they have changed altogether, completely. Everything is multiple choice, scenario-based. And actually, all these individual scenarios are authentic simulations that are derived from real practice. Similarly, in OSCEs, the original OSCE was a short station where you assessed skills in isolation. For example, you assessed the knee, the examination of the knee. In real life, there's never a single knee that you see. There's always a person attached to it and a story to come along with it. So also in OSCEs, making the stimulus format as authentic as possible is something which is important. And that's what you're measuring. So you're not measuring something because the method has a certain wrapping, a certain response format, but you're measuring something because you put something into it. You gave certain tasks to the learner, which determine what you're measuring. Here's sort of a holy Bible of item writing, which can be found on the web, which is from the National Board of Medical Examiners in the US, actually showing how scenarios can best be written. Right. The practical implication is that you shouldn't worry too much about the response format, but about the stimulus formats, about the things that you put into the exam. And then I'll come to my next principle. That is that in standardized assessment technology, validity can be built in. That is that if you have a review system around your tests, meaning that someone else overlooks the quality of your test material, for example, by test committees. If you have such a review process that has an enormous impact on the quality of your material, an enormous impact. Does any one of you have, in your regular exam systems, review panels of your exams? Can I see hands? 1, 2, 3. Yeah. This is kind of the normal situation. We typically don't quality assure our test materials. And I can assure you that if you do that, it has a huge impact. And actually, if you look at the quality of the exams in a random higher education situation, we would shred it to pieces easily in terms of quality. So developing high quality test material is costful, resource intensive. So why not share? Why do we all, as teachers, have to have our own drawer with a set of individual poorly written questions that we keep away from the students? Huh? You give them to the students, but then we keep them away to keep them secret, which never happens, because if you do that, I've not been to a medical school in the world where they secretly keep the questions, where there was not a flourishing black market. The students know. They're smart. Here's an example of the Maastricht review process. On every assessment in Maastricht is being reviewed by panels. Not going to expand on this at all. The fact that you need quality assurance, that is important. So the implication is that the validity is just as good as you're being prepared to build into it. And therefore, you have to build quality assurance cycles around good test development. And then why not share good test material across institutions? In the Netherlands, we develop what we call a progress test, which is sort of a final exam, which we give periodically to all of our students, which is a comprehensive multiple choice exam across all disciplines, 4 times a year, to all the students in the curriculum. Very costly test. However, we do that with 5 different medical schools. We co-produce the same test. And the same test is being set by some 8,000 students in the Netherlands, 4 times a year. Sharing good test material, that's pretty important. And then finally, I wish I could flash this in neon. Assessment drives learning, but later on in my next talk, I'm going to be a little bit more critical about that. But assessment drives learning. I mean, you set the cheese into the maze for the student. The success, academic success, is defined by the exams, so that's what the students will focus on. For the students, the exams is the curriculum. And they'll do anything to pass, whatever is needed, with the least of effort. Because we're all homo economicus, and you can't blame them. For us as teachers, we're very much involved in the curriculum. But for the students, it's the assessment which is important. Now, there's no problem if there's a tight connection between the curriculum and the assessment, between the goals of the curriculum and the goals of the assessment. Often, there isn't. And there's a poor link. And we have lots of fancy objectives, academic objectives, with our students. But they're just as good as our exam system is. Right. There are lots of empirical findings, but one empirical finding that has been well researched now is that a lot of the impact on the learning of the student is pretty undesirable. A lot of cramming, a lot of short-term memory focuses is often stimulated by our exams. And often students go from exam to exam, wipe out the hard disk entirely to move on to the next exam, and so on and so forth. It's kind of an outdated model of learning. And one other thing which comes across real clear is that we provide very little feedback from our exams. And grades are the poorest form of feedback you can give. If you were to grade me on this presentation, and you would give me a 7 out of a 10, fine. What should I do next? Yeah, get an 8. Huh? But how do I do that? So most of our exams are information poor, are not really very helpful for learning. It fits to a very sort of outdated model of education. Course, exam, if you pass, you're immune for life. If you fail, you have to repeat without much information, simply, or repeat the exam first. That's the remedy. And then, if you fail again, repeat the course. Without, blindly, I mean, without any sort of further information. So there's little information. This is also very much true for the clinical workplace, for clinical rotations, and for postgraduate training. Learners wanting feedback, not getting it. Particularly in clinical rotations, it is striking how few learners are directly observed by clinicians. Striking, really. I've heard residents talk about not being observed at all during their postgraduate training program, which I think is horrible. Right. So my recommendation would be to monitor, to evaluate the effects of your assessment on the learners, and perhaps even strategically adapt your assessment program to reinforce desirable learning strategies. And in my view, there should be no assessment without feedback. Feedback is essential for learning. You can't give a 6-year-old child a violin and say, come back in 6 years. It doesn't work that way. Feedback is essential to learning. Exams can be part of the learning process by providing more feedback. I know it's hard, We don't have the time. Tedious. But we have to do it. Right. The sixth principle, the last one for the standardized testing, is that there's no magical bullet. There's not a single instrument that can do it all. If you wish to assess the whole competency pyramid of Miller, you have to have different methods to assess different layers. And in order to do a good job, you have to have a cocktail of different methods in order to be able to do that. Combine the information and use the assessment strategically to foster the learning. And that's in line with all the previous messages. One measure is no measure. All methods have limitations. Different methods may serve a different function. But maybe that in combination, these different methods may compensate each other's deficiencies. And together, in an arrangement, would make a good combination. So to me, what I learned from these principles is that I think that we should arrange the assessment in a deliberate mixture of a program of assessment, just like we do nowadays with the curriculum. Let me describe the curriculum in the old days. In the old days, we had a bunch of disciplines, each discipline responsible for their course. That was it. The professor of the discipline determined the content of the course. We saw many disadvantages to that model, and we started to coordinate the curriculum. We define what we do in the curriculum. We define what we do over here, come back over there, and so on and so forth. It's an arranged, coordinated program, which is smart. I mean, we couldn't have an orchestra in which each musician would play his own part. So an arranged curriculum is smart. And in my view, an arranged assessment program belongs to an arranged curriculum. So you have a deliberate assessment program with some writing over here, some presenting over there, some reflection over there, and so on and so forth, in an arranged, predefined, agreed sort of assessment curriculum. Unlike a curriculum, every 10 years, it's worn out, and you need to rethink the whole system. Like a curriculum, you need to evaluate it properly and periodically and adapt your system to that. Okay, the does, and I'm through actually because it's finished, but 1 minute, okay, Ron? Because I'm going to highlight only one thing, which is very different from the standardized assessment technology. That is that the value of the instruments that are being used to assess people in the real practice are extremely dependent on how these people use these instruments. In an OSCE station, you can sharpen the instrument, but for example, by having very good patient instructions, very good examiner instructions, training of examiners, a standard setting procedure for knowing when to fail and to pass, and so on and so forth. You sharpen the instrument. However, at the DOS level, you don't sharpen the instrument, you sharpen the people. The people are very important. The way the people take the evaluation seriously and give proper feedback is very much dependent on these people themselves. They need to understand why they're doing it. And then the final comment, that is that qualitative narrative information, descriptive information, is there much and much and much more important than the quantitative information. Assessment is very much connected to quantification. However, at the DOS level, in real practice, looking at performance, looking at behavior, descriptions, language is very important. Not easy to get, but that's the challenge. Right. Finally, assessment, I think, has gone through a very rich history of development and research. And I think we covered quite some ground. And I think these principles are sound. They apply to any sort of assessment situation, I think. And if you look at the literature, then the assessment literature is primarily dominated by psychometrics, by studies about reliability and validity of individual assessment instruments. There's very little about how to stimulate learning, how to provide feedback in such a way that it stimulates learning. So we need a lot more research in that area. There's very little about how to design an overall assessment program, and I'll come back to that this afternoon. But anyway, assessment is much more, in my view, than a psychometric problem. It's an education design problem, because that's what we're after. We're after educating learners. And lots of exciting developments are still ahead of us. And if you want a full scientific account to these principles, they can be found in this particular reference. Thank you much for your attention.